honored to be here today to talk about this gender inequality in Australia. I am pleased to have this opportunity to speak on this exciting topic. As Professor Okubo has requested me to talk about how I started working as a medical practitioner and what I'm doing in Australia today. So today's talk, I will describe how to get started working as a medical doctor in Australia medical system and how medical education there is different from that of Japan. Then I will look at the gender-based inequality in the workplace and what Australians are doing to achieve equality. So first of all, I came to Australia for my research in cochlear implant. After coming to Australia a second time, I tried to get into the specialist pathway to medical registration. However, I was not successful. Then I sat the Australian Medical Council exam and found a position in the Royal Victorian Eye and Ear Hospital. The Royal Victorian Eye and Ear Hospital is a specialized hospital for ophthalmology and otolaryngology. It was established in the 1860s in East Melbourne. As otolaryngologists, we are managing patients in the area of ear, nose, and throat. The nucleus cochlear implant device was invented in the Bionic Ear Institute next to the hospital. Next to the hospital, Bionic Ear. So, since the first successful operation in 1978. Now I'm working as an ENT physician in the emergency department, mainly supervising emergency and ENT unaccredited registrars. I also work in the balance disorder and ataxia service. My main interests are having hearing and balance disorders, such as differential diagnosis between central and peripheral vertigo, and Meniere's disease and vestibular migraine. Last month, I went to the International Meniere's Conference in Rome and presented to a review of Hydrops MRI, initially invented in Japan. We are aiming to introduce this diagnostic to Australia, which doesn't have it yet. So I have been very fortunate having great supervisors to encourage and support me to continue my work in Japan and Australia. As you know, Professor Suzuki is a savior for patients suffering from dizziness, especially the positional vertigo. Professor Funasaka, who initially started cochlear implant operation in Japan in 1985. Stephen is Professor of otolaryngology. Professor of otolaryngology and University of Melbourne. He leads a cochlear implant team and is an authority on hearing preservation. David is the director of Balance Clinic and passionate neurologist in vestibular disorder and cerebellar ataxia. And Carmel is the director of emergency department in eye and ear. She is dedicated to patient safety and diagnostic error. As you can see, 1 in 5 is the female director. Now, turning to the Australian medical system, in order to start working as a medical doctor, you need to be registered. There are 2 main organizations you have to contact when you apply to work. One is Australian Medical Council, AMC, and Australian Health Practitioner Regulation Agency, AHPRA. It is quite a complex process for doctors to work in Australia. There are 4 basic steps which are shown in this slide. 1. Skills recognition through an AMC assessment process. Number 2. Apply to the APLA for registration. Number 3. Arrange a pre-employment structured clinical interview if required. Number 4. Apply for a visa. Temporary visas like the 457 and 442 is applicable for the temporary workers. In the AMC assessment process, there are 2 assessment pathways available. After having finished the primary medical qualification in countries other than Australia and New Zealand, standard pathway, AMC examination, and the specialist pathway. So, to change the subject. So how many doctors are working in the medical workplace in Australia today? So in 2015, according to the Medical Board of Australia, the total number of registered doctors is 100,470. As annual registration is required, this means doctors actually working. The ratio of 3 per 1,000 is bigger than for Japan, 2.2 per 1,000. According to 2009 figures, clinicians constituted 82% of the total, and the percentage of specialists and GPs was similar at 36 to 38%. The total population of Australia is 24 million in 2015 for an area of 20 times the size of Japan. 90% live in the metropolitan areas, but only 10% rural areas. In such a big country, the concentration of doctors in the metropolitan area and the shortage in the rural areas has always been a big issue. Furthermore, while the ratio of primary care practitioners, including GPs, to specialists is almost equal in the major cities, in regional and remote areas, there is a significant shortage of specialists. So, what about gender equality in Australian medical workplace? When I was studying for AMC exam, one of the senior tutors of the bridging course, who was an Egyptian orthopedic surgeon, told us that this is the baseline social hierarchy in Australia, which we would do well to remember when we start working in Australian medical workforce. Women are the top, then kids, then aged and disabled, and the men is the last under the pets. So this shows doctors, especially males from countries in which men are thought that they are superior to women, can be confronted by the apparent gender equality in Australian society. Furthermore, as overseas trained doctors, we have to acknowledge Australian cultural diversity and respect different nationalities, languages, and cultures. Awareness of our own prejudice may be the first step in equality and fairness in the workplace. For this, verbal communication is the key element. At a public hospital, teamwork and collaboration amongst related health professionals are essential for the best outcome of patient care. In a multidisciplinary team, not only doctors but also nurses and other allied health professionals can assume leadership depending on the problems that patients present with. With the decline in prestige for doctors and the rise of a more equal medical culture and a more enlightened educational system, Australian medical students are more mature, focused, and independent. They aspire to be a medical doctor from their own interests and motivations rather than because of family pressure and or social expectations. The focus of student training is on field experience rather than purely academic learning. As a result, novice doctors are able to work by themselves under supervision after graduation. They are also aware of the importance of work-life balance and the option of career change and early retirement. In Australian medical school today, 1/3 of universities have adopted the postgraduate system. This slide shows a postgraduate pathway. After completing 1 year's internship, they are eligible for general registration without board exam. After working as a hospital medical officer for 1 to multiple years, similar to the junior resident in Japan, they then enter the specialist training program offered by a specialist college for 3 to 8 years. However, the number of accredited positions for registrars vary depending on the college and some are very difficult to enter. For example, placement for cardiology, neurosurgery, ENT, and plastic surgery are very competitive. After entering the program, they will rotate from hospital to hospital annually. The registration has to be renewed every year. I have been impressed by the activity of the Australian Medical Student Association, AMSA. AMSA is the peak representative body of all 17,000 Australian medical students and operates in conjunction with Australian medical associations. AMSA advocates in the area of student welfare with particular emphasis on gender equality and the impact that inequality has on student health outcomes. Student development, particularly in the area of non-academic education, and leadership with a regular program of events and publications, as well as building awareness of global, rural, and indigenous health issues. Australia has achieved complete gender equality in education and literacy. However, gender discrimination has been nevertheless a long-standing issue within Australia. Although there have been many significant gains in this area, according to the Global Gender Gap Report 2013, Australia only ranked 24th out of 136 countries in terms of average score of economy, health, education, and politics, and 63rd in terms of wage equality. All over, Japan is in 105th position. While many gains have been made, gender discrimination still plays a large role in the culture of Australian medicine, in medical schools and workplace, and disparity in pay rate, medical attitude, and the high proportion of men in leadership roles. So in general, increased female workforce participation is demonstrated, and this is also reflected in the medical workforce. In 1996, the Australian Medical Workforce Advisory Committee stated the female medical workforce is growing at a much faster rate than the male medical workforce, and it is projected that women will comprise 30% of the medical workforce by 2000 and 42% of the medical workforce by 2025. But actually, the total female registered medical practitioners in 2015 is 40% and is expected to be 50% by 2022. There is a generational shift among both men and women in relation to the balance between personal and professional lives. Their priorities are radically different from those of their senior, older colleagues. A 2012 an Australian study of doctors' preference for choice of specialty, in which 61% of the respondents were women, reported that work-life balance and the capacity to provide continuity of care with opportunities for academic or hands-on work were highly influential, with a tendency for female doctors to value work-life balance and family responsibility, and male to be attracted to professional challenges and procedural work. Conventionally, career options within medicine favored by women have been perceived to have more flexible training and work environments and little or no requirement for irregular work and time on call. Hence, women are more highly represented amongst specialties such as general practice, anesthesia, psychiatry, dermatology, and obstetrics and gynecology. As this slide shows, in 2009, only 10% of surgeons in Australia were female, with 3 of 5 specialties with the least number of females being surgical. So supporting for the women in medical workplace, what's going on? So all employers, males and female, can get parental leave when a child is born or adopted. The minimum is non-paid leave. However, limited financial support for up to 18 weeks is available to help eligible parents take time off work or care for a newborn or recently adopted child. A right to return to the old job in 12 months is guaranteed, and if applied for, an additional year's leave is possible. A government rebate up to 50% of out-of-pocket expenses for child care is also available for all parents. But the reality is that child care is very expensive, so doctors have a 1-year maternity leave, or the husband can help the female doctor. Another subject. So for doctors, clinical training in hospital is involved working in a team structure headed by a consultant with the least experienced intern at the bottom. This crucial phase, a time when the dynamics of hierarchy and interpersonal relationship enhance or impair learning, can influence career choice. Good supervisors can have positive influence on career choice. Conversely, bad ones can quickly diminish aspiration. In order to assume professional identity, trainees absorb the medical culture. Many argue that this is necessary for success, but enculturation can lead students to believe that the progress in medicine requires them to accept the way things are. Students quickly learn that conformity is a crucial component of professional advancement. Complaints is not an option. So, what we can we do? A system for responding to complaining about the behavior of supervisors should be transparent and accessible to medical students. Otherwise, this reinforces the belief that nothing can or should change. Targeted education is required with accountable and transparent process in place to ensure that zero tolerance for harassment and discrimination. To male and female trainees is the norm. So it has been suggested one way to change the situation is to use the media. In March this year, complaints of bullying and harassment of female surgical trainees reached the media. The Royal Australian College of Surgeons established an expert advisory panel to examine its bullying culture. The President issued an apology and admitted it should have done more to help those affected. Leadership. This one is already told by Dr. Jagsy, but despite the increased participation of women in the medical workforce, they are still underrepresented in the upper tier of leadership. Evidence suggested that lack of interest is not a causal factor. Rather, systemic break in the leadership pipeline where women are discouraged or prevented from continuing up the career ladder are to blame. Another reason for the current gap in leadership is a lack of female supervisors and mentors. Recognizing this,